All right, so we're going to start the evening talking about the horse's foot, and we're going to cover a lot of information. For being such a relatively small part of the horse's body, the foot plays an incredibly important role in soundness. The horse's hooves are definitely one of my favorite things to talk about. Equine podiatry is one of my passions, so I really had to dial it back to try and fit everything into a talk that we could do in one evening. I think it's simply amazing to consider all the functions that are occurring in this structure that support the horse of that size and weight. We're also going to talk a lot about biomechanics and how this relates to the function of the foot. And we can make a world of difference in the horse's life and athletic career by optimizing the biomechanics of the foot. The critical importance of the horse's feet can be summed up by the traditional adage that you may have all heard: no foot, no horse. If you don't have a healthy foot, might as well not have a horse. Okay, pointer here. So it was really difficult to condense everything I wanted to cover into a short talk. Each of the topics that we're going to cover can easily have an hour or more of lecture time. In fact, it was a 3-hour course I went to last year dedicated to these topics. But hopefully this overview will give you some key things to consider regarding the horse's foot and how important good hoof care is. So we'll start by talking about anatomy and biomechanics, and then we'll visit some of the diagnostic imaging options, look at some of the radiographic anatomy that we assess, talk about the importance of shooting survey films, and then we'll go on to some of the lameness issues and common conditions, and then just touch briefly on the role of the farrier and the importance of the good relationship between that team. So, if we look overall at the horse's foot, it's made up of the distal phalanges. These are known more commonly as the coffin bone, which is the brown bone down at the bottom, the short pastern bone, which is the purple bone there, and the long pastern bone, which is the green bone there. So these three bones together are the equivalent of the human fingertip. They're surrounded by soft tissues and encased in an exterior hoof wall and horn of the sole. And these are made up of keratin, which is the same material as the human fingernail or toenail. So the end result is that a horse, weighing on average 1,100 pounds, travels around on the same bones as with a human on their tiptoe. So I think that's pretty fascinating. So if we look at it in a little more detail, the coffin bone, which is this bone here, is suspended within the hoof capsule on 3 sides by the laminae, and I've got another picture in a few slides to show you that. The laminae are essentially underneath the hoof wall and stuck to the coffin bone like Velcro. So they suspend the coffin bone on 3 sides, and then at the back it's suspended by the deep digital flexor tendon, which is shown in yellow on the diagram on the right. So that deep digital flexor tendon runs all the way up the back of the leg to the flexor muscles, which are up above the knee, and help control movement of the foot. There's also another tendon that's not shown on this one, the extensor tendon, that comes down and attaches on the front of the coffin bone, that also plays a role in the suspension of the bone in there. So the coffin bone, in conjunction with this deep, our digital cushion back here, which is shown in orange, and is this structure here, those are responsible for acting as the main shock absorbers that transfer the weight-bearing forces from the hoof to the skeletal system. The navicular bone, which is this little bone here, and is shown in the diagram there, whose correct name is the distal sesamoid bone, but we all just refer to it as the navicular bone. It's located at the back of the foot, at about the level of the heel bolts, and it's tucked in between the short pastern bone and the coffin bone at the back of the foot. So that little tiny bone acts as a fulcrum for this deep digital flexor tendon as it comes down and attaches on the coffin bone. So the deep digital flexor tendon without the navicular bone has to make a pretty sharp turn there. So it just helps to ease the stress on the flexor tendon as it makes the turn and attaches on the back of the coffin bone. In between those two structures, there's a little fluid-filled sac called the navicular bursa that acts as a cushion between the tendon and the bone. And then some other important soft tissue structures to be aware of are the collateral ligaments of the coffin joint that run on either side, the impart ligament of the navicular bone, so it's a tiny little ligament between the navicular and the coffin bone, and then what's called the collateral ligament, or some people refer to it as the suspensory ligament of the navicular bone, which holds the navicular bone up to the short pastern bone. So all of these structures are susceptible to injury, and we're becoming increasingly aware of their role in lameness that originates in the foot. And then the hoof wall, it grows from the coronary band, which is at the top here, so that would be where the haired limb meets the hoof wall. Hoof wall occurs from the coronary band down, and it's only happening at a rate of about 6 to 10 millimeters a month. So it actually takes 9 to 12 months to grow a foot again. So it's an important factor to consider when you think about treating things and waiting for something to grow out. It actually takes a really long time for the foot to grow. So if you could go to the next slide, please. So then we need to talk about biomechanics. And according to dictionary.com, biomechanics is the study of the mechanics of the movement of living organisms. And I know it sounds really boring, so the moment I say it, some of you are going to probably start to tune me out. But it's actually a really key concept when we consider the actions of the horse's foot and how we can improve these with trimming and shoeing. So bear with me, I'm going to try and make this part as painless as possible, and then we'll move on to the more interesting things. So the factors that affect biomechanics in the foot are, number one, the weight of the horse. So these 4 feet suspend all the weight of 1,100 pounds weight of the horse as it transfers down the limb. Equal and opposite to that, the ground is exerting force on the foot as well. It's called the ground reaction force. So it's equal and opposite to the weight. And then we've got the deep digital flexor tendon at the back, which exerts a pulling force up the leg. And then the attachment of the laminae opposite of that hold the coffin bone and velcro it against the hoof wall. So problems can develop when there's prolonged abnormal loading or forces on the foot that can occur with improper hoof growth, trimming, or shoeing. And those factors tend to move that center of pressure of that ground reaction force towards the toe or towards the back of the foot, depending on what's going wrong, and create some abnormal forces and throw this out of whack. So it's actually inappropriate biomechanics that's the root of nearly all equine foot problems, or the majority of them anyways. So these factors become really important when we consider what changes to make with therapeutic shoeing treatment options. And in altering the biomechanics of the foot, that's the key to alleviating the discomfort for a lot of horses out there. So the next two concepts that we need to be aware of when we're thinking of this are what's called the center of articulation and the hoof pastern axis. The center of articulation, which is shown in red on this diagram here, is sometimes referred to as the center of rotation of the coffin joint. So it's essentially what this joint has to rotate around in order to move forward. When we draw a line through that center of rotation and go down to the bottom of the foot, that should actually approximate the widest part of the foot. So if you're looking at the foot from the bottom, where the widest part is, that should be where the center of articulation is. And we'll get into this a little bit more when we talk about the shoeing concepts. The other thing that we need to be aware of is the hoof pastern axis. So that's shown in yellow on the diagram on the left, and it's also shown in this right-hand diagram. So the hoof pastern axis is the alignment of the hoof wall with the pastern above it. So the hoof wall and the pastern, and those should be parallel. It should be a pretty straight line between those two. So if the pastern winds up being steeper than the toe, that's what we call a broken back hoof pastern axis. This is often caused by excessive toe length or too little heel length, and tends to result in excessive load on the back of the foot. So it shifts that ground reaction force to the back of the foot. And that leads to crushing of that digital cushion, which is supposed to be acting as our shock absorber, and increases the stress on the deep digital flexor tendon. If, on the other hand, like shown in this little diagram here, the toe is steeper than the pastern, that's what we call a broken forward hoof pastern axis. And this is often due to the conformational defect known as the club foot, which we'll get to in a little bit. When that happens, it tends to overload the toe, so it shifts that center of pressure of the ground reaction forward to the toe, which underutilizes that digital cushion at the back of the foot and results in less shock absorption and more jarring of the structures all the way up the leg. Both of those alterations in the hoof pastern axis mean that the joints are in an abnormal articulation, so they're not lined up like they should be. And when they're loaded at angles other than what they were meant for, it can result in arthritic changes and eventually lameness. So we want to try and avoid that. So we're going to go over a very brief overview of a good basic trim. Often we can't achieve everything we want to with just a trim, but what can't be achieved with a trim can often be achieved with proper shoe selection and placement on the foot. So using these principles that we're going to talk about allows our foot to be evaluated by me. This is what I look at. It allows it to be trimmed and shod in a consistent and reproducible manner. I don't claim to be a farrier by any means, but these are the principles that I tend to use when I'm evaluating the foot and assessing what farriery has been employed to that point. So the first thing, we want to take into account our biomechanical principles and the landmarks that are associated with those to help serve us as guidelines. So the first one that we look at, we're just looking at a horse's leg, is the hoof pastern axis. So that angle of the front of the hoof wall with the pastern bone. And the angle, the correct angle for a hoof wall is when that hoof pastern axis is straight, not necessarily when the hoof angle approaches a certain number. The next thing that we want to look at is that center of articulation. So remember in the last slide we talked about if we were to draw a line straight down from that center of rotation of that coffin joint, it should approximate the widest part of the foot, which is the red line there. And then the next thing we want to consider is that we want our heels to be brought back to the base of the frog. So that's the base of our frog there, the yellow line. If we can do that, it's going to make the most use of that digital cushion at the back of the foot. All too often I see heels that are being left too far forward and then become underrun. And so that just creates some extra stress and strain on those tissues and doesn't optimize the use of that digital cushion. So again, often we can't achieve that with just trimming alone without removing too much foot mass and actually making the horse sore. So that usually necessitates that the branch of the shoe or some other form of farrier helps us come back there and shift that load to the back of the foot. So after your trim, the ground surface of the foot should ideally be as wide as it is long. And you should have about 50% of the foot in front of it and 50% behind. So that should kind of have that crosshair look like that. So this was the best spot I thought to talk about breakover as well. Breakover is a concept that you hear me talk about quite a lot when I'm talking about feet. And it essentially just means how the point at which the foot breaks off the ground. So when they're going to move the foot forward, it's the point where the foot is able to leave the ground. So in an unshod foot, it's right at the tip of the toe there. They have to get all the way over the tip of that toe in order to bring that foot off the ground. But that's something that we can adjust with different types of shoes to help certain disorders. So we can move the breakover back by rounding the shoe or setting the shoe back or whatnot and then ease breakover. You'll hear me use that term a lot. That just essentially means we're making it easier for that foot to move off the ground. So these factors are, like I said, just a general overview, but they're often adjusted if a patient presents with lameness originating in the foot based on the specifics of their particular problem and what we need to achieve to optimize their biomechanics. So then I thought we'd touch on what we look at. So once we've determined that a lameness is originating in the foot through our lameness exam and nerve blocks and things like that, then we have to look into the foot and try to figure out what exactly is going on that's causing the lameness. So by far and large, the radiology or x-rays is probably the #1 way that we look at the foot. The limitation of radiology, unfortunately, is that it only allows us to see the bone and the biomechanics of the foot. That doesn't allow us to see much detail about the soft tissue structures in the foot. An extension on x-rays or radiology are what's known as venograms. So that's what's shown up in this upper right here. So a venogram is when we put a radio-opaque dye into the blood vessels that go to the limb, which allows us to look at that entire vascular tree and see whether or not it's healthy. And we'll talk about that a little bit more when we look at laminitis. MRI, or magnetic resonance imaging, which is this image here, is probably the gold standard for looking at a foot. It's one of the only ways that we can really look at both the soft tissue structures and the bones together. But it's becoming increasingly available, but it's still hard to find, and it is somewhat costly, so we don't get to jump to that all that often. It has, however, allowed us to learn a lot more what's going on in a lame foot than we ever knew before, because we're just getting that much more detail, and it definitely allows us to get the most accurate diagnosis about it, so we do consider it quite often. Nuclear scintigraphy is what's known as a bone scan. So that's this image down here on the left. So it may help us localize the lameness to the foot, but it's really not very specific for what exactly is causing the lameness. So we just get this little area of uptake of increased metabolic activity, this dark spot on there, which tells us there's something going on in the foot, but it really doesn't tell us what that is. Ultrasound is out there too. I'd say it's really challenging to image the structures through the hoof wall and the sole, so it's got pretty limited use. We don't tend to use it very much in the foot. And then CT, or computed tomography, which is this image here, is really not readily available, so we rarely ever get to jump to that option. So if we think about radiographs as being our most common way of looking at the foot, I thought we'd better give you some radiographic anatomy of what we're looking at. So this is an x-ray of a horse's foot on the right-hand side, and this is an anatomy specimen to give you a frame of reference. So the short pastern bone is this bone here, the navicular bone tucked in at the back, the coffin bone down at the bottom, and then in between those is the coffin joint. On the front of this x-ray here, you'll see that white line, and I often put a radiopaque marker on the outside hoof wall, so that's the front of the hoof wall. There's a little bit of a black space between what we can see on the x-ray and this white line, and so that white line just allows me to mark the actual outside extent of the hoof wall. But as you can see in this radiograph, there's very little information about these soft tissue structures that we can see in the anatomy specimen. We really don't get much detail about those. But there are some really important information that we can gain from these radiographs that we'll look at in the next slide here. Go ahead and advance it one more, please. So the first thing I look at when I'm assessing a radiograph of a foot is the center of articulation. So that was our circle around where our center of rotation is with a line drawn at the bottom of the foot. And then I look and see how much foot is behind it, and how much foot is in front of it, and helps me guide where I want my middle of my shoe to be typically, or bottom of the belly of the rocker when we get to talking about that. And the next thing I measure, if you can advance it again, is what's known as the palmar angle. So the palmar angle, you heard me refer to a lot as well, is the angle of the wings of the coffin bone in relation to the ground surface. So as a general rule of thumb, we say it should be about 3 to 5 degrees, but it really does vary quite widely between different ages and breed and use of horse, but 3 to 5 degrees is the general average. When we start to get a 0 palmar angle, so it becomes parallel with the ground surface, or a negative palmar angle, so this wings are actually lower than the tip, that's a problem. We don't want that to happen, and we need to make some adjustments to the foot to help them out with that. So the next thing I look at, if you can advance it one more for me, is what's known as the horn lamellar zones. So that is the distance from the outside of the coffin bone to the hoof wall. We can measure that and see if there's any signs of thickening, or if the bottom one is bigger than the top one, we know that bone's starting to rotate and emit some signs of laminitis. So we measure that as well. Digital breakover is one more thing we can measure on the x-ray. So that's the distance from the tip of P3 to the front of the foot. So that's how long that horse has in front of the tip of that bone that it has to rotate over. And we can definitely alter that with different shoe selection and placement quite a bit. Sole depth is the distance from the tip of P3 to the ground. This should be ideally about 15 to 18 millimeters for them to have adequate protection of the coffin bone and for them to have enough blood flow underneath the coffin bone. But we see a lot of horses that have less than that. We definitely have to be aware of that when we're shoeing them and riding them, so that we know whether or not that's going to present a problem. And then I measure what's known as the tendon surface angle. So that's the angle that the deep digital flexor tendon is running down across that fulcrum to attach on the back of the coffin bone. This is another angle that if we can alter that in some disorders, we can make that horse significantly more comfortable. And finally, we look at the digital alignment. So how well are those 3 bones lined up? They should pretty well be in a straight line. If they're not, if they're broken back or broken forward, obviously that's a concern. So radiographs for this purpose, we have to take a little bit lower than we normally would a foot radiograph. Normally we're aiming up around here, the coffin joint or the navicular bone with our beam of our x-ray. So these ones we have to just drop it down and take so that we're parallel through those wings of the coffin bone. So it's a little bit different than your just average foot film. And definitely all of these details are really important parameters for us to know when we make decisions regarding trimming and shoeing in order to optimize the biomechanics of the foot. So one way that we can make use of these is through the use of shoeing survey films. So these are x-rays that we can take as a screening basis to help us detect problems early and make appropriate adjustments to their feet to help us prevent these problems in the future. So I've heard it referred to that it's a similar benefit as taking your car to the mechanic or checking your pressure in your tires to prevent a flat tire. That it's just one way that we can detect issues before they become a full-blown problem. And definitely, after looking at a ton of x-rays, our thoughts and ideas about how the bone is oriented in that hoof capsule when we look at the foot is often quite a bit different than what it is on the x-rays. So we can gain a lot of information when we think we know where the bone is in there, but when we look at the x-ray, it's often quite a bit different than what we thought. So they're a really good investment, especially for top prospects or performance horses, but definitely in my mind should be considered when purchasing a new horse so that you know what you're getting into in terms of farriery and whether they've got a potential for problems there. And then quite often they form part of a lameness examination for us too in helping us formulate a treatment plan for the horse. All right, so now we'll move on and talk about some of the common conditions of the foot and how these factors relate to them. Lameness originating in the foot is one of the very most common things we see in day-to-day practice. It can have a significant impact on the horse's usability and certainly has a negative impact on the horse's ability to perform at its very best. By no means is this an exhaustive list of the problems that can affect the foot, but these are the most common issues that we see originating the foot, so I thought we'd better talk about them. So the first one that somewhat goes unrecognized is what's called mismatched feet. And I have to fess up and say that this is actually my horse here, so I did buy a horse with mismatched feet. But it's essentially a front foot conformation where one foot has a higher angle at the toe than the other foot. So if you look at this from the side, this angle is higher than this one. And in addition to the disparity in the toe angles, we often have a difference in the heel height. So you can see her right front is quite a bit higher than the left front. We also tend to see a difference in the size of the feet, the overall hoof wall growth, and the hoof pastern axis tends to be different between the two feet. Causes, we think are probably genetic has some role in it. I've heard that developmental tends to play a role. Some people think that foals that tend to graze with their legs splayed, because their short little neck can reach the ground to graze, that they tend to always put the same foot forward, the same foot back, and that can set them up for this, because the front foot's getting overloaded and the back foot isn't bearing as much weight. So it's an interesting concept, and I think it might play a role. I don't know how well it's been proven, but it's definitely interesting. Differences in exercise and loading, and definitely pain in the foot. Pain can cause changes in the orientation of the hoof capsule as well. So this is really common. About 28% of sound competition horses are affected, but it can contribute to poor performance, subtle lameness, and it definitely makes them have a decreased anterior phase of stride. So what I mean by that is that foot doesn't actually travel as far forward as the opposite foot. And it tends to land toe first, which results in some bruising at the foot. So it's some pretty subtle things that we see, but in some of these, really athletic horses, that can be enough to change the game for them. And because that upright foot tends to have a decreased anterior phase of stride, or decreased forward motion in that foot, it means that the foot with the low angle tends to get overloaded. So there's increased stress in that foot on the navicular bone and the flexor tendon. That foot also tends to have a longer distance from the center of articulation to the toe, so it's harder for them to break over on that foot and takes more force for them to use it. So when we're addressing this, our goal with Farriery is not to match and make the two feet pretty and make them look like each other, but to address each foot individually and try and optimize the biomechanics in each foot. So radiographs are really actually quite necessary in order for us to do that. Helps us make a plan on how we're going to improve the biomechanics in the foot. Our overall goals are to improve the hoof pastern axis of each foot, decrease the forces that are necessary to move that coffin joint, improve the structures at the heel, and decrease the stress on the deep flexor tendon. And that center of articulation that we talked about, that we can see on the x-rays, is often our guideline for trimming and shoe placement. And then we address the breakover and any heel elevation if necessary. So these are something, like I said, that tend to go somewhat unrecognized, but there's definitely negative impacts that it can have on performance, and we kind of want to be aware of them and address that. If you want to go to the next slide, a more severe version of this is what's known as a club foot. Ah, halfway already. Oh my God, I gotta talk faster. So club feet are one of the most common deformities in the horse world. They're a result of, they're an upright conformation of the foot that's associated with flexural deformity of the coffin joint due to a shortening of the musculotendinous unit. So it's a really complicated way to say essentially that this muscle up here is abnormally short. It's got a persistent degree of contraction, which then makes this whole thing shorter. So this green thing is the deep digital flexor tendon. They can be born with this, meaning it's congenital, or sometimes they can develop it later in life. It can be acquired. There's various theories out there about what might trigger the syndrome, but none of them have been scientifically proven. So we essentially don't really know why this happens. But it definitely has some biomechanical impacts on the foot. So the tension from that deep flexor tendon is overwhelming those opposing forces, which changes the orientation of the bone in the hoof capsule, breaks that bone and hoof pastern axis forward, and deforms the hoof capsule. So these horses are definitely at a significant risk of chronic lameness, but if we can recognize it early and intervene appropriately, sometimes we can correct them. So we'll go through this slide really quick. These are just the different grades of a club foot. Grade 1 is the easiest one to miss because you don't really see too much difference in the outside hoof capsule. But essentially what's happening is that the palmar angle, so the tendon is pulling this bone so that the angle is about 5 degrees steeper than the opposite foot. And then as we get into the higher grades, we're just essentially seeing more and more pull of that flexor tendon, a sharper angle of the bone in there, which creates some deformities in the hoof capsule and some changes in the coronary band. So management of these, Farriery plays a huge role in it, and our goal with that is just to, like I said, improve biomechanical function. You are going to get tired of that phrase. But what we want to do essentially is change it from a foot that looks like this. So a club foot, they're essentially standing on their tiptoe all day long because this tendon up the back of the leg is too tight. So what we want to do is make it look more like that. So we want to redistribute the load over the entire foot, reposition our breakover, so instead of them having to lift up further to get that toe over, now they just have to kind of pop over. The breakover is quite a bit better. And then we often have to give them some degree of heel elevation because we can't change how tight that flexor tendon is. So if we take their heels back and redistribute the load back there, we then have to elevate their heels so that that tendon's not even tighter than it was when we started. We're going to talk a little bit over the next few slides about these rocker shoes, and I'll show you one. Trusty Farrier happened to give me a sample. So a rocker shoe is something that's been out there for a while, but it's just something that we're just learning now how to use this appropriately and how to put this on a horse. So it's a very different concept. When you look at it, it's like, oh my God, what the heck is that? But there's a few things that this shoe does that can be very helpful for changing those biomechanics in the foot. So in this case, when we rocker a shoe on a horse with a bit of a club foot, we want to place the belly of our shoe, so the bottom of this curve, below the center of articulation, and then we load the heel at the widest part of the frog. That decreases the tension on the deep flexor tendon and redistributes the load to the heel and helps improve the blood flow to the toe of these horses. So it's one area that we're starting to use these and really think they're having a beneficial effect. And then in our more severe cases, we have to actually think about cutting the ligament or the tendon itself. If that foot's so upright that we can't change it with Farriery, we have to think about doing something more dramatic to try and get that tendon to lengthen so that our foot's going to be normal in the long run. Conversely to that, the opposite that we tend to see are underrun heels. These are also, some people call these low heels or crushed heels, and this is an incredibly common problem that we see in our practice. Essentially what's happening here, if you want to hit the button for me, is that the angle, this horse was the perfect one. I had to take a picture of this one because you can see the striations in his hoof wall. It gave me a really good idea of what was going on in that foot. So these striations should actually be parallel, but what's happening is that this heel is being run forward. So the angle at the heel is no longer parallel with the angle at the toe. So these heels have started to migrate forward, which causes them to bear more weight. They collapse, they fold in and go forward. This all stretches the deep flexor tendon and results in increased tension, which then stresses our poor little navicular bone back there. It also makes it so that our digital cushion, which is back here about where the yellow arrow is not really being engaged, so it's not really doing its job as a shock absorber. So lameness can develop with these horses due to just heel pain of the soft tissues in the heel. This is a common cause of navicular bone pain or soft tissue pain in the navicular region. The causes for this, we think, are mostly just stress from a long toe. The foot always wants to grow forward. That's where it's going to go. So if the foot's left too long for too long, this is what we're going to start to see, is those heels are just going to follow the toe forward. Some horses are also just born with a low heel. We just have to try and address that as they grow up. And sometimes just poor quality hooves. If they're wet all the time and they're weak, they can tend to want to run forward like this too. And so what happens is that we now get way more toe in front of our widest part of the foot than we've got behind it. So the whole foot has to work a heck of a lot harder to break over. When we look at an x-ray, thank you, and we look at that center of rotation and where it is, you can really see that there is a heck of a lot more foot in front of it than there is behind. So these horses have to work a lot harder to rotate this joint and break over. And they've got a lot more force. That ground reaction force has shifted to the back of the foot. And now it's causing a lot more stress back there. This also often causes a broken back hoof pastern axis. You can see that these bones are no longer in alignment. They're broken back. And a low palmar angle, or sometimes even a negative palmar angle. So sometimes if we catch it early, these are reversible, but when it's been going on for a long time, we often have some secondary changes to the foot that make it really tough to actually reverse it. So in these horses, radiographs really are essential to help us gain the appropriate information that we need to guide the proper trim. So we need information regarding the sole depth, center of articulation, the palmar angle, and the hoof pastern axis in order to know what we need to change. Our goals of Farriery are to provide protection to and improve the structure of the heels if we can. So it's really important that shoes are not set on heel tubules when they're rolled under. It's only going to make the problem worse. We're just going to keep crushing those tubules. So our tubules at our heel need to be loaded on end. So that's one thing that we really have to pay attention to. But we also have to maintain the proper heel height, which is critical to keep that navicular bone and the flexor tendon from getting too much strain. And then we typically want to set our shoe back so that we get back to that balance of having 50% of the foot in front and 50% behind to help decrease the stress in the foot. This is another disorder that can benefit from these funky rocker shoes. So what those do for us is help to enhance the blood flow to the sole and really change our palmar angle and our tendon surface angle. So this horse here, before the trim, had a palmar angle, so the angle of the wings of its coffin bone of about 4.5 degrees, and a tendon surface angle of 42 degrees. And then you can see she was broken back. She also, unfortunately, had a lot of other pathology in the leg that was making her quite sore. So we decided to put a rocker on this horse with that belly of the shoe right under the center of articulation, which changed her palmar angle to 11.5 degrees. That is a huge difference in the angle of that bone, and changed our tendon surface angle to 51 degrees from 42. So there's a lot less tension on the navicular bone. And then the alignment of our bones is better. This horse is unfortunately on the way to fusing that pastern joint, so we weren't going to change this one too much because it's almost stuck together. But overall, we've got better alignment there. And this case was pretty amazing because this mare went from being pretty well crippled at the walk to being sound after we put these shoes on, so we were pretty happy with that. So, one of the other things we see not uncommonly are hoof cracks, and hoof cracks are essentially fractures of the hoof capsule. They're typically named, in our world anyways, after their location, so they can either be at the toe, at the quarter, at the heel, or in the bar. They can vary from very small, insignificant findings that are just on the outside of the hoof wall and don't extend through to the sensitive tissues, to full thickness cracks that go all the way through, desensitize the hoof, or destabilize the hoof wall, pardon me, and can be very painful for the horse and prone to becoming infected. So it's typically a combination of factors that affect the quality of the horn. Environmental conditions that are wet or alternating wet-dry tend to set them up for this problem. Dr. Rick Redden, who's one of the podiatry specialists that I've learned a lot from, uses the comparison that a cornified foot to water is like cardboard to water. If you get cardboard wet, it loses a lot of its strength. So it's very, very similar in the foot. So these can start up at the coronary band, or they can start at the toe and work their way up. Oh, sorry, I jumped ahead of myself. We'll go back to talking about the rest of the causes here. So genetics can also play a role. Horses that have small feet, long toes, thin walls or soles, or underrun heels can be really prone to it. Nutrition plays a role. If they're not getting enough vitamins and nutrients, that can definitely play a role. Shoeing practices, if the foot happens to be improperly balanced, or if it's been allowed to grow too long, it creates some changes the biomechanics and changes the forces on the hoof wall. Trauma can affect this as well. Abscesses or wounds to the coronary band that affect the growth of the hoof from the coronary band down can all play a role, as well as stable management, exercise, use of the horse. There's lots of things that can cause them. So, like I said, they're not uncommon for us to see. Treatment is essentially a team approach between the veterinarian and the farrier. Our goal with the farrier is to have them balance the foot properly and apply therapeutic shoeing and stabilization techniques that sometimes rely on clips on the shoe or a bar shoe to help stabilize that foot and prevent that crack from moving. And then we tend to debride that crack and stabilize it with some wires and some composite. And we'll show you some pictures of that in the next slide. So this little filly here actually had a pretty severe crack at her toe. Her feet had just gotten a little long. It was one of the years where it was really wet for us, so she got this really smoking bad crack. And it actually ended up getting infected and breaking out of the coronary band. So we put a bar shoe on her with clips on either side. A little hard to see on this slide, but there's clips on either side to help stabilize that wall. Dremelled it back to healthy tissue. Wired it with some stainless steel wires so it kind of act like reinforcing rods and concrete. And then put this Equinox composite patch on there with some fiberglass in it. So she had a nice strong hoof wall after we were done and allowed that foot to grow out more normally again. She was also quite lame beforehand because that hoof wall crack wanted to wiggle quite a bit, so this just stabilized it so it no longer wiggled and pinched her all the time. All right, and then we'll move on and talk about laminitis. And I definitely cannot do this disease justice by covering it in a few slides during this presentation. It's a disease that can't be left out when we're talking about equine podiatry. It's probably the most devastating disease of the equine foot. It's extremely painful and one of the top reasons for euthanasia of a horse. So it is essentially inflammation of the laminae. And the laminae are these little feather-like attachments, the Velcro attachments that attach the coffin bone to the outside hoof wall. When they get inflamed, they swell and they tear, which results in failure. If you could hit enter for me, please. Got a cool little animation. Oh, look at that, tearing. So when they tear, it results in failure of the suspension of the bone to the hoof capsule. The deep flexor tendon, however, is not affected by this, so it continues to pull on the coffin bone in the opposite direction all the time. So that tends to result in rotation of this coffin bone away from that hoof wall. The weight of the horse also needs to be considered. They still need to carry the weight of their body, so it's still acting as a force down on the foot. And without proper attachment of the coffin bone at the front, it can lead to sinking. So that weight of the horse actually drives that bone all the way down to the ground in the hoof capsule. So that's what we refer to as sinking. So both sinking and rotation can cause shearing and tearing of the arteries and veins that go to the foot. So this is one spot where we use those venograms that I showed you the picture of to help us assess the blood flow to the foot. It helps us assess the severity of it. If they really don't have any more blood flow to their foot, it's not a good scenario. You're going to have a hard time getting it back. So that's one place where that can come in handy. Don't have time to go into much detail regarding causes and whatnot, but we'll focus on the effect this disease has on the biomechanics, and our goal is when trimming and shoeing these patients. So in the acute stage, if we catch this early, our emphasis of our emergency treatment is on the mechanical component. So we sometimes use these boots that are known as modified ultimates, that are shown on the right here. And what they do is substantially alter that palmar angle. They can make it up to 20 degrees or greater and decrease the tension on the deep digital flexor tendon. It has been shown to decrease that tension about 50 to 60%. So it just decreases the amount that tendon is pulling on the back of that bone. It also allows us to shift the pressure on when the bone is rotated, all that ground reaction force is hitting the tip of that bone. So it allows us to shift that pressure over the whole foot and back to the heels, where typically we have better blood supply back there anyways and they're more comfortable. When we put those on, we have to make sure that our wings of our coffin bone our heels are trimmed parallel to the wings of the coffin bone in order to see the best desired effect from that. And then inside there's a little glob of gray stuff, but that shows up bright white on the x-rays is what's called advanced cushion support. It's just an impression material that makes them more comfortable inside those boots. So that's what we do in the early stages. If, however, we're getting to them in the chronic stages, so it's been going on for some time, that's when we start to see remodeling of the coffin bone. So it started to change shape because of that abnormal force it's been taking. The top of it is blunted and remodeled, and the outside hoof capsule has also become distorted because of those abnormal forces. So when that happens, when the rotation of the bone is tipped down, all these little small blood vessels and capillaries underneath the bone are essentially pinched off. So it makes it really hard for those patients to grow any sole. So our goals are to try and improve blood flow to the foot, restore a more normal alignment of the bone within the hoof capsule, and transfer the load from the tip of the bone back to the heel. So we can do that, we can use a rocker shoe for that, like we've been talking to before, where we put that belly under the center of articulation, transfers our load back to the heel, and takes the stress off of the sole. What Dr. Rick Redden has shown with these shoes is that these patients can also grow a substantial amount of sole with this shoe because it takes that pressure off of the capillaries at the toe. So this patient has been battling chronic laminitis for 5 or 6 years and is really quite happy in his new shoes now. So again, happy to see that. So some of the more traditional approaches to it, we'll go over the next 2 slides. We often also think of it again, as a derotation trim. We try and align that bone back up in the hoof capsule normally. So I don't know if you at the back can see, there's 2 little lines here, one here and one there. So we want to try and trim it so that that bone is more well aligned within the hoof capsule again and distribute that load back to the heels again. You know, unfortunately, if we were just to leave a horse like that, if we just cut their foot like that, that's only going to increase that tension from the deep flexor tendon back here. So we usually wind up having to wedge that back up with a wedge pad or something to try and maintain the same tension on that flexor tendon. And the next slide here is another horse that's very similar, just to a lesser degree, where we just need to try and shift that weight back and restore more normal alignment of that bone in the hoof capsule. And these patients, for sure, there's no way that we know what this bone is doing in a foot if we're just looking at a laminitic horse. It's impossible to know where the bone is without having some x-rays to help guide us. How am I doing for time? Which couple clippers left? Okay, I'll carry on. Navicular disease we'll touch on next. And again, unfortunately, I don't have time within the realm of this talk to cover this disease in great detail because it's very complex. And it involves not only the bone itself, but also the adjacent soft tissue support structures. So we make a diagnosis of this based on the results of our lameness examination, what we find with hoof testers, and where the horse blocks with nerve blocks. And then we tend to look at the foot with some imaging. So again, x-rays are our most common way to do that. This view here is a skyline projection, allows us to see this little navicular bone a little bit better. And this little mare actually had some pretty remarkable sclerosis. So that just means that bone's been under stress for a long period of time, and the body's tried to strengthen it by remodeling it and laying down new bones. So it's a lot brighter and whiter than it should be. This horse over here actually has a big hole in the navicular bone right there. And that hole actually was adhered right to the tendon that you can see in the specimen down here. These little white fibers are tendon fibers. So that horse was in a lot of discomfort because that tendon was actually stuck to the back of its bone. So treatments that we generally enlist for this are bisphosphonates. Those are what most people know as Tildren or Osphos. They stop that bone remodeling and treat bone pain in some cases. Fortunately, it doesn't work all the time, and nothing with navicular disease works all the time, which is why it's so frustrating. So then we'll also tend to enlist the help of some non-steroidal anti-inflammatories, sometimes Butte, Banamine, Previcox, Meloxicam, some pain medications essentially for some of these horses. Sometimes we'll try and inject the coffin joint with the navicular bursa. Oh God, there she is. Okay. When we inject the coffin joint with the navicular bursa, we're essentially just trying to target some anti-inflammatories right around that structure. And there's been some recent research at the WCVM that supports the use of shockwave in some horses with heel pain to try and get them some pain relief. But in my opinion, perhaps one of the more effective ways in some cases of providing these horses with some pain relief is altering the biomechanics of the foot to reduce stress on this region. I'm almost done, bear with me. So therapeutic shoeing, when we address navicular disease, we're attempting to shoe them with the goal of altering their biomechanics to improve their heel support and decrease their breakover. We want to make the most of the digital cushion's shock absorbing capabilities at the back by shifting the load back to that region. And then we also want to decrease how hard the horse has to work and how much they have to engage those tissues at the back of the foot in order to lift that foot off the ground and bring it forward, so that we ease their breakover essentially. And then also in altering our palmar angle, which is the yellow, and the tendon surface angle, which is the red, those two things also offer us a pretty reliable means of alleviating or managing the pain associated with this disease in some cases. So this can be accomplished with wedge pads and shoes, egg bar shoes with or without a wedge, and rocker shoes as well in this case. And the choice of which to use we usually make based on the individual characteristics of that horse's foot. We'll breeze through this pretty quickly, but we alluded to those soft tissue structures in the foot. They can injure any one of those in the foot, just under bad luck circumstances usually. Our best way for looking at those and actually getting a diagnosis is with that MRI, where we can actually see those tissues. So most of the time we target this with rest and rehabilitation, sometimes some biologicals like platelet-rich plasma or stem cells, but occasionally we do use some therapeutic shoeing in these instances as well if we want to support those injured structures or transfer the stress away from those injured structures. And then the last thing we'll talk about here are sole abscesses. So these are actually a really common cause of really sudden severe lameness. We see these a lot. And anything that weakens the hoof wall and the sole integrity and makes it easier for bacteria to gain access into those interior hoof structures, and that's typically via the sole wall junction, but sometimes we can see it up near the bars or heels or anywhere in the foot really. But wet to dry environmental conditions weaken tiny little hoof cracks and fissures that allow bacteria to get in there, penetrating wounds if they step on something sharp, close nail or a hot nail, so if when a shoe's been nailed on, if it's just gotten a little too close to the sensitive inner structures, that can allow bacteria to get in there. Bruising, blood underneath the hoof capsule is a really good place for bacteria to grow, so if they happen to gain access into there, a bruise can set them up for an abscess. If the hoof is out of balance or their conformation is off, they can get some abnormal forces that cause cracks that can become contaminated. And then, of course, management factors where they're poorly maintained stalls that are wet a lot of the time. Laminitis, they're also really prone to abscesses because that attachment has been broken down, so they've got a really weak sole wall junction. So we diagnose these based on clinical signs and hoof test or examination usually, but sometimes we do use x-rays in this case as well. The patient on the next slide, it's a little tricky to see in here, but I'll point it out. There's a really dark shadow on this x-ray right here. So this horse had a massive foot abscess that actually went up and infected its bone as well. So that was really important for us to know because we also had to treat that a little bit more aggressively with some antibiotics and some debridement. And so that was one other shoe I wanted to show you that we use sometimes, if you can go to the next slide for me, is what's called a hospital plate. So definitely not all abscesses do we need to put a hospital plate on. Usually we just open that abscess up, soak it, pull to sit, keep a bandage on it. But in certain situations like this horse where that infection actually extended down to the bone and affected a lot of the inner structures, we wound up using a hospital plate so that they could just screw this plate on and off and treat the foot underneath there. Allowed that horse to grow some sole back and he was quite a bit more comfortable with that. So then I thought I couldn't do a talk on podiatry without talking about the importance of this relationship. So you have to, if we're trying to address these things, we really have to find a talented farrier and have someone that can work alongside us. So we want the veterinarian, the farrier, the client, and the patient all to be on the same page. Treating the majority of these conditions requires a lot of cooperation between us all, so it's really important that everyone can communicate with each other. So, in summary, a proper analysis of the abnormal forces acting on the foot must be performed in order to apply the appropriate therapeutic shoeing strategies. Altering the biomechanics of the foot is the key to managing most of the disorders affecting the foot. And radiographs really are essential in providing us the information that's necessary to evaluate the existing biomechanics and to determine the appropriate changes that need to be made. And then just a list of references of where I got all my good stuff. Any questions?
Did you offer a basic assessment?
Mm-hmm. Yeah, we've got a radiographic package that we just term our shoeing survey film package, where essentially we just take 2 views of each front foot, perform all those measurements and decide whether or not they're appropriately balanced or if there's something that we should be doing differently.
Yeah, just gives you a baseline to work from.
Yeah, exactly. Yeah.
Thank you.
Man, I did good. Nobody's got a question. Yeah, go ahead.
Is it okay to keep a horse shoed?
Yeah, and there's a lot of controversy out there, and actually I had meant to touch on that in one of my slides before I got prodded into hurrying up. But
Sorry about that.
Yeah. So it's a difficult topic to address for sure, and I guess all I can say really is that not all horses can go barefoot, but on the flip side, not all horses need shoes. But we really have to look at each horse individually to decide whether or not they would do better biomechanically with a shoe on or whether they could tolerate being left barefoot. So, and definitely those radiographs help us decide because knowing where that bone is in there is really difficult to see when you just look at the foot. All right.
Just a real quick question. If someone was doing a pre-purchase on a younger horse, say a yearling or something, is there a minimum age at which a radiograph makes sense as part of a pre-purchase exam?
Yeah, that's a really great question. So we just asked in a young horse, like a yearling prospect or something like that, is there a minimum age that is recommended for taking shoeing survey films or taking radiographs of the feet? And I'd say there's no cut and dry answer to that, but definitely we can start to see some of these problems like club feet or mismatched feet at a very young age. So a yearling is really a good time to detect it. 2-year-olds, 3-year-olds before they go into training. You really want to get on this before it becomes a problem where they've been in training already and they're starting to develop some of the pain and the lameness associated with it. So definitely we can detect some of these things. And the lower grade clubs are the ones that are really hard to pick up sometimes, but visually when we are on the radiographs, when we compare them, we can often pick it up there and know that we need to address that. So, good question. Yeah.
The bulk of the examples you were showing up there look like they were front feet.
Yes.
Now, the hind feet not have as many of the same issues, or you're just...
No, I would have just had to double my tongue, which I would not have gotten away with. So. Well, I would say that you know, the front feet are responsible for the majority of lamenesses in the horse, so they're where we focus most of our attention. The hind feet can have the exact same problems. They're just usually to a lesser extent, and they don't have quite as much of an impact on lameness, but definitely we often need to take some radiographs of those feet too. There's a lot of horses that are probably having low heels behind that can affect the hind limb structures as well.
Is that because a horse bears most of its weight on its front end?
60%, yeah, that's right. 60% of their weight they bear in their front end. So, so those front feet are taking a lot more load than the rest. Yeah.
Are you leaning towards saying the horse should be shoed all the time? I'm not sure where you're having it mixed up.
I don't want to throw myself under the bus, but I really feel that shoes make a difference for horses biomechanically. I think the horse that can go barefoot is a rarity, in my opinion. That's just one person's opinion.